Good morning. So this is my disclosure. As we know that the obesity is a problem, especially where I come from, in the Gulf region. You can see that the percentage of prevalence of obesity around between 30 to 40%. Just to give you some perspective that where I come from, the Gulf region, you can see the size. It's almost the size of Europe. Number of balloons in our region, you can see it was increasingly increased from 2011, from 4,000 balloons to 8,000, so it's doubled. These are the types of intragastric balloons that have been in the market, and 3 of those are FDA approved: the Apollo Endosurgery, Reshape, and the O-Balloon. In my practice, I do Orbera, O-Balloon, SPATS 3, and Ellipse device. So our indication for the BMI for the balloon in Kuwait is around 27 to 40. As we know, in the States, the FDA approved is 30 to 40. And I use the balloon in high BMI patient selectively as a bridge procedure. Contraindication is as recommended by our societies. So this is an example of using a balloon as a bridge. So this case was we went in for a sleeve gastrectomy because of the size of the liver, as you can see, and it was difficult to retract it. It was difficult. So we end up having a balloon in this patient as a bridge in the same side. You can see the laparoscopy light is there. And then we came back after the balloon removal. You can see the big difference in terms of the liver size and the ease of the procedure. So to reduce the complication because of the large liver this patient has. So in my practice, this is an overview. So I will talk about consent medication that's been used before balloons, during the balloon, the role of endoscopy, body measurement, combination therapy for weight loss, multidisciplinary team, and which hospital center has to do with the balloon, the importance of first visits to the emergency room, and the follow-up, use of technology as well. So the consent, we have to explain really risk and benefits of the procedure, as well as we have to have realistic weight loss when we speak to the patient in terms of percentage of weight loss. And we have to speak also in terms of each complication in details. We have this circulated in our government and private hospitals, in all the hospitals in Kuwait. So in my practice, I usually give medication Imand a day before, day of insertion, and day after, PPI as well. We give it 1 week before insertion and ongoing until the balloon removal. We use ondansetron 3 times a day. We use Buscopan as needed and some painkillers. So this is the evidence regarding using Imand and ondansetron from the bariatric literature as well as from the plastic surgery literature. These are randomized studies show that using both of those medications reduce nausea and vomiting. And recently published data, you can see here, from the Ellipse data last month, showed that using these 2 types of anti-nausea medications really help with the nausea and vomiting. So body measurement is another trick that we can use. You know, some patients, they don't lose weight on the scale. However, the body size and measurement get reduced. So I highly recommend that you do body measurement as well in addition to the weight to have more satisfied patients, even if their scale in terms of weight did not change. Combination therapy, I recommend using, in my practice, I use a GLP-1 analog that will help and aid with more weight loss. It's been recently approved by the FDA. So this is the data regarding using of weight loss medication. At least from all the patients in this study, more than 5% of total body weight loss happened to those patients. So this is in the bariatric literature, and it's a good study that shows. So we can use as a tip also weight loss medication in addition to the balloons. So the role of endoscopy, as from the previous speakers, that's important to understand if there is any contraindication for surgery. This is our earlier study published in Surgical Endoscopy. In our population, we found that the balloon worked very well for lower BMI and with the female gender. However, you can see after 6 months from the balloon removal, there's a weight regain in 30%, 35% of those patients. This is a meta-analysis that showed that in most of those studies, the balloons lose about more than 25% of the excess weight loss. And this is another trick that we use in our practice as well, that if the patient removes the balloon, we can always put another balloon, and this data showed that having balloon after balloon with a month of a break has a better result than having a balloon followed by a diet. This is a randomized study. So the technique of balloons, there's different types of fluid-filled balloon. We have spats, we have the orbera. So each one has different techniques, so we have to have courses for each of those to understand how the technique is in terms of how much fluid we have to put in. And I use the size between the balloon and the stomach wall, and if there is a space, by looking at the endoscopy, I can decide how much fluid to put in, but we don't have any standard for that. In terms of balloon removal, I think my practice, we do 2 days of liquid diet before removal. We have to have removal kit. I do all the fluid-filled balloon under GA. We use McGill forceps just in case the balloon gets stuck in the upper airway. If the balloon gets stuck in the esophagus, we try to push it back to the stomach and then remove it. As we know, we use general anesthesia because there's some reports of aspiration leading even to death because of the aspiration of food material if you don't do it under GA. Other trick also, we use sometimes Coca-Cola just a day before to clear up the stomach from food. Okay, so here's some videos that shows that we have food material even when you have endoscopy and the patient is intubated, and you can see that there is this under GA with intubation will protect from aspiration. There is different techniques for each of those balloons, as you can see. In terms of air-filled balloon, there is only a few studies in the literature. Our own study was published, was presented here last year in SAGES with 58 patients, and we found with the air-filled balloon, it's really good, but the weight loss in our practice was less than the fluid-filled balloon. Now we changed our practice. We used to put 2 balloons in those patients, and now we've been doing 3 balloons to have a better result. You can see here the technique for balloon removal for the O balloon. You can see there's 3 balloons. The good thing about this balloon, we don't have any food material get stuck to it, so compared to the fluid-filled balloon. So we don't keep them fasting or on liquid diet for 2 days. We use it as a standard endoscopy. You can see there's 3 balloons. There's different techniques of doing that. Hopefully with 3 balloons, we have a better results. So also we have experience with the ellipse balloon, which is the procedures gastric balloon. We're more than welcome to attend. Our lecture will be on Thursday on the emerging technology session. So basically the result of, we have included 135 patients with the ellipse balloon, which is a swallowable balloon that gets excreted after 4 months in the stool. We have really good result in terms of weight loss, with 52 excess weight loss at 4 months. So what I like about this balloon is that it comes with an electronic scale and an app application that could be used to measure different aspects of patients, like for example the weight, the body fat, and so on. And then we can always have a good follow-up in terms of sending the patient messages. We can follow the patients without them being in our clinic. So this is one of my assistants that we had the balloon. You can see that it was interactive between me and him, and we have really good result with those. In terms of complications, that could be ranging from pain to perforations to early removal, about 7.5%. And as last month, there was an FDA statement regarding overinflation and pancreatitis. This is some of our patients that had hyperinflation. You can see the balloon gets filled with air. The mechanism behind that, I'm not sure about that, but we've seen that in a few of our patients. In terms of perforation and migration, you can see that here, this patient presented to us with small bowel obstruction. We have to go in and explore those patients. As you can see, there's balloon was stuck in the small bowel, and we have to do enterotomy and remove the balloon, and by laparoscopy, of course. You can see that this is very rare, but it could happen. That's why it's very important that you have to affiliate yourself with a center where we have access to operating room or to a surgeon that we are able to deal with such complications. So these are some literature about gastric perforation following gastric balloon. There's few of them, and the most important thing, you don't want to do a balloon in a patient who has previous gastric surgeries. So this is one of the patient presented with perforation. On the right side, a perforation of the fundus, as you can see, after we deflated the balloon by endoscopy. The second on the left side, the video is showing that the body of the stomach is perforated, and this patient ended up with a gastrectomy. So be careful with these patients when they present and try to interfere early. So, and also it's very important that when you do the indication for those kind of balloons, that the patient has not be on blood thinning medication. This patient was on blood thinning medications because of DVT, presented us with hematemesis and abdominal pain 3 days after the balloon. You can see that there's a lot of blood in the stomach. It was ulcer, kind of Miller-Weiss type of ulcer, the lower esophagus. So we have to deal with such complications as well. This patient, we just removed the balloon, and he did very well afterward. But I think it's very important to get more history for those patients, especially if we use kind of procedural balloons. We have to make sure that they don't have any contraindication. You can see this is the valve of the balloon. So to summarize, I think it's very important that you take your time with the consent and give this patient realistic weight loss outcomes. Medications, I think the trick here to use medication with PPI before, combine 2 medications together to have less vomiting and nausea, so reduce your early removal. Endoscopy, if the history indicates that you need to do endoscopy, you have to do it to make sure there's no contraindication. Body measurement, I think it's very important, especially the patient, if they don't lose weight, but if they lose inches, then they will be very satisfied and they follow your program. In terms of combination therapy, I think I talked about that, using different medical treatments that will help in addition to the balloon, to have combination of the balloon as well as the medication. I think the team is important, especially the anesthesia part of it. I think some of those balloons require general anesthesia, some of those will not. Hospital, you have to be affiliated with the hospital just in case if the complication happened, that you can deal with it. First week of after the balloon, some of those patients will require readmissions for rehydration and so on. So we have to take care of that. Follow up. I think I gave you a good example of using apps or technology to make sure that you have a better follow up with those kind of balloons. So I would like to thank you for your time. Thank you.